Good afternoon, everyone. Thank you for joining today's webinar, What's New in the Enhanced National CLAS Standards. Today's webinar is sponsored by the Hopkins Center for Health Disparity Solutions. Before we begin, I want to make sure that everyone can actually hear the audio. If you could click the button that looks like a hand to indicate that you can actually hear, I'd appreciate that. Very good. Thank you very much. So let me begin with a little bit of information about our center. The Hopkins Center for Health Disparity Solutions was founded in 2002 by Dr. Thomas Leviste. Our center is a research unit of the Johns Hopkins Bloomberg School of Public Health. Our center is funded by the National Institutes of Health, National Institute on Minority Health and Health Disparities, and has been designated a National Center of Excellence in Health Disparities Research. So, a few general housekeeping rules. If you experience any technical difficulties, please contact GoToMeeting.com corporate account customer support at either of the numbers listed below. And also, another quick show of hands. I was mortified at 2:30 to see that GoToMeeting was actually down, and it came up around 2:45 Eastern Time today. So, quick show of hands. Did anyone have any difficulties actually logging into the system today? A few people did. Yeah, if a couple of people tried to log in early, you might have received a message saying that the system was down. Thankfully, it is back up and running. So I thank you for your diligence in that, and we'll keep going. So I wanted to also remind you, in order to have full audio capabilities, if you are dialing in via telephone, please enter the audio pin, which appears when you log into GoToMeeting. Otherwise, you can actually listen via your computer, and if you click the audio settings, there is something that says computer and mic. In addition, for attendance purposes, although we do not actually offer CEs or CMEs for our webinars, you do need to click on the GoToMeeting link that you received in your email in order to access the system. Usually what happens is if you didn't click the right area, following the webinar, you will receive either an email saying, thank you for attending, et cetera, or you will receive an email that says, sorry you missed the webinar. If you receive one of those sorry you missed the webinar emails, please email me and I can look in to see what actually happened. Also, we are going to have a Q&A session at the end of the presentation. However, you can feel free to type in any questions during the actual webinar. A quick reminder, today's webinar is being recorded, and the presentation slides and the webinar recording will be available on our center's website soon after the webinar. So a few quick items that our center is currently working on. Our center has developed a suite of tools for a variety of healthcare organizations. We actually have 3 different tools available. We have a COA 360, which is for either hospitals or healthcare organizations. We have a PCMH 360, which is for medical practices, either basically standalone medical practices or those who are trying to achieve patient-centered medical home recognition. And we also now have a BHSS 360, which is for behavioral health and social service settings. And if you would like more information about any of these tools, please feel free to visit our website at www.clearview360.org. One of our other programs is the Cultural Quality Collaborative, or the CQC. And this is a network of leading healthcare organizations that is working in conjunction with the Hopkins Center for Health Disparities Solutions faculty and select cultural competency consultants. Our member organizations participate in webinars, and they have access to the members-only section of the CQC website. Additional information about the CQC is also available on the clearview360.org website. And now I'd like to turn the presentation over to today's presenter, Darci L. Graves, who is a Senior Health Education and Policy Specialist in the Health Determinants and Disparities practice at SRA International, Inc. Thank you, Darci.
Thank you, Cherie. Good afternoon. It is always a pleasure to be speaking to the audience that is drawn to the Hopkins Center for Health Disparities Solutions webinars. As Cherie indicated, my name is Darci Graves, and I am a member of the Health Determinants and Disparities practice at SRA International. It was our team that helped to lead and manage the enhancement initiative of the National CLAS Standards on behalf of and in conjunction with the HHS Office of Minority Health. So that is the lens with which I'll be talking about the national standards today. I am particularly pleased to be talking to you today because today, which is still difficult for me to fathom, but today marks exactly 90 days since we re-released the National CLAS Standards after an extensive enhancement initiative, which I will discuss in a bit more detail in a moment. Something that you'll notice as we go through the presentation is I will not generally refer to them as the enhanced National CLAS Standards, and that is because we wanted to consider them a living, breathing document that in the future will likely be enhanced again, and we did not or do not want to add descriptors to the title, which may ultimately become outdated. So the enhanced would become the re-enhanced, and so on. Nor did we want to approach this as with a technology mentality. So a la the iPhone have National CLAS Standards 3, National CLAS Standards 4. These are, in fact, the National CLAS Standards as they stand today. So that's what we'll be discussing. With all of that said, our learning objectives today are as follows: to define culture and health as they stand within the current National CLAS Standards, describe the target audiences and intended recipients of the standards, describe key differences between the 2000 and 2013 iterations of the National CLAS Standards, and then be able to access resources on how to implement the National CLAS Standards. And I don't appear to be able to advance the slides, so I'm going to ask Cherie, thank you. As I said, the National CLAS Standards are an initiative of the Department of Health and Human Services, Office of Minority Health. The mission of the Office of Minority Health is to improve the health of racial and ethnic minority populations through the development of health policies and programs that aim to eliminate health disparities. As you may know, there is a significant body of research that documents the persistent and widespread disparities experienced by many communities in our nation. The Secretary for Health and Human Services, Kathleen Sebelius, has noted that minorities and low-income Americans are more likely to be sick and less likely to get the care that they need. The Office of Minority Health has several important cultural and linguistic competency initiatives to help address these disparities, including over a decade of work with the National CLAS Standards. So we move on to the next slide, where we discuss, what exactly are culturally and linguistically appropriate services. They are services that are respectful of and responsive to individual cultural health beliefs and practices, preferred languages, health literacy levels, and communication needs. CLAS is employed by all members of an organization, regardless of its size, and at every point of contact. CLAS is about treating all individuals with respect and in accordance with their culture and language. I think it's important to note that every point of contact is called out here and spelled out here, because very often when we talk about cultural and linguistic appropriate services or cultural and linguistic competency, we focus on the patient-provider interaction. So within the clinic room, within the exam room walls. But really the interactions or the points of contact with our communities extend well beyond those four walls. It's how they hear about your organization. It's about how they arrive at your organization, how they navigate through the building from the waiting room to the exam room to any sort of laboratory work that they may need to do, or x-rays. It's billing, it's follow-up, it's referrals. So really there is a place for culturally linguistically appropriate services throughout the patient contact continuum. Culturally and linguistically appropriate services are increasingly recognized as effective in improving the quality of care and services. CLAS helps health professionals build rapport and a trusting relationship with individuals to personalize their care, improve their adherence, and increase their overall satisfaction. The Assistant Secretary for Health, Dr. Code, noted in his speaking at the launch of the National CLAS Standards in April that care needs to be delivered with class. And obviously we can see the multiple layers there. So what are the National CLAS Standards? We move on to the next slide. They were first published by the HHS Office of Minority Health in 2000, and essentially they provide a framework for organizations to best serve the nation's diverse communities. The National Standards for Culturally and Linguistically Appropriate Services in Health and Healthcare essentially help us to operationalize what are sometimes considered nebulous subjects of cultural and linguistic competency. The standards provide 15 different ways that culturally and linguistically appropriate services can be used and applied within any sort of setting. Following 10 years, so in 2010, we began the Enhancement Initiative. The Enhancement Initiative lasted from 2010 to 2013. It had three major components: a public comment period, a systematic literature review, and ongoing consultations with an advisory committee comprised of 36 experts from a variety of settings in the public and private sectors. But why were the National CLAS Standards enhanced? In the 2000s, there was tremendous growth in the field of culturally and linguistically appropriate services, significant changes in our nation's demographics and policies, and legislation around the country continue to evolve, including the passage of the Affordable Care Act. The National CLAS Standards were enhanced in response to each of these developments. With the Institute of Medicine's publication of Unequal Treatment in 2003, culturally and linguistically appropriate services gained recognition as an important way to help address the persistent disparities faced by our nation's diverse communities. Many important publications and initiatives since then have also furthered the field, so the National CLAS Standards were revised to reflect these developments. There have also been rapid changes in the demographic trends in the U.S., and therefore the standards provide guidance for best serving our nation's growing minority and diversifying communities. In addition, healthcare policies and legislation, such as the Affordable Care Act, have helped to underscore the importance of cultural and linguistic competency and culturally and linguistically appropriate services as a part of high-quality health care and services. So what is the purpose of the enhancements and the enhanced National CLAS Standards? Well, the National CLAS Standards are intended to advance health equity, improve quality, and help eliminate healthcare disparities by establishing a blueprint for health and healthcare organizations to implement and provide culturally and linguistically appropriate services. These enhanced standards offer an even stronger framework to address the new developments and trends. The standards work to this end, and this purpose statement, as I will refer to in a moment, is a statement of intent, and now is essentially the lead-in sentence for each of the new standards. So what's new in the National CLAS Standards? So I'm going to highlight some of the major areas of revision in the conceptual foundation or underpinnings of the standards. For one, our definitions of culture and of health, as well as who our target audience is. If you look at all the revisions together, you'll see that the overall themes of those include our inclusion, expansion, and guidance. What we heard from the public comment, the advisory committee, and the literature review was the National CLAS Standards should be more inclusive of different cultural groups as well as health professionals, and we updated the standards to reflect this. This broad scope will facilitate the involvement of stakeholders at every level and in every role of health, in achieving health equity by providing culturally and linguistically appropriate services. What we also heard was that from the public comment was a request for additional guidance, implementation strategies, and information on the purpose of the standards and the case for CLAS overall. So one of the things that is new in the National CLAS Standards is the addition of a statement of intent, as I just alluded to. There are many individuals out there that we heard from who had seen the list of the 14 standards within the 2000 iteration, and they said, that's great, these are the national standards, but what is their purpose? What is their intent? And so we wanted to make sure that if people didn't receive the blueprint or didn't know that the blueprint existed or couldn't access it, but they received this list of now 15 standards, they knew what the intent and purpose was. So again, the statement of intent, which appears at the top of that list, now reads, the National CLAS Standards are intended to advance health equity, improve quality, help eliminate healthcare disparities by establishing a blueprint for health and healthcare organizations to implement culturally and linguistically appropriate services. And we really see that as our charge. The next thing that is new is our definition of culture. In the original iteration of the standards, culture was primarily confined to racial and ethnic and linguistic groups. Again, based on the literature and what we heard loudly in the public comment, was that culture needed to be broadened. It needed to be much more inclusive and recognize individuals who have multiple identities. And therefore, we look at now as culture is defined as the integrated pattern of thoughts, communications, actions, customs, beliefs, values, and institutions associated wholly or partially with racial, ethnic, or linguistic groups, as well as religious, spiritual, biological, geographical, or sociological characteristics. Culture is dynamic in nature, and individuals may identify with multiple cultures over the course of their lifetime. So within this definition, we now recognize religion, sexual orientation, socioeconomic status, military service, all of these components which can impact the way people perceive and receive their health and healthcare are now included in this definition of culture. And there are many more examples of who is included in that in the resource document that I will highlight later. The next new thing that I want to highlight in the National CLAS Standards is our definition of health. The original National CLAS Standards did not explicitly define health, but what we found in our discussions with community members, with those who provided public comment, was that the perception was that it was isolated to physical health. And so as a result, we wanted to make sure that we explicitly broadened the definition of health. So building on the WHO definition, we say that that health is clearly defined as encompassing many aspects, including physical, mental, social, and spiritual well-being. So we want to make sure that all four of these elements can be and could be and should be recognized as elements of health and well-being. Moving on to the next item, the target audience. The audience is also broader than this 2000 iteration, which focused entirely on healthcare organizations. As a part of the enhancement initiative, we moved to health and healthcare organizations. A health organization is any public or private institution addressing individual or community health and well-being. By expanding the definition of health, we're reaching more professionals and organizations who should implement the National CLAS Standards. We're moving beyond the hospital walls to also encompass public health, social work, community health centers, emergency health services, and more. Furthermore, the National CLAS Standards refers to individuals and groups instead of patients and consumers in order to reflect the expansion from health care to health. And now we'll highlight briefly the guidance document and resource, and I'll talk more about it at the close of this presentation. But again, one of the things that was called for in the public comment was enhanced implementation guidance. People wanted more direction, more resources, more background information. So what we did was we developed and provided a blueprint for advancing and sustaining CLAS policy and practice. And this document includes standard-by-standard chapters which describe the standard, its purpose, and some strategies and resources for implementing the standard. The blueprint also includes a section called the case for CLAS, which walks individuals through both the business case and the social justice case for why CLAS is important, and provides a concise overview of the enhancements. The blueprint is available exclusively for download on the Think Cultural Health website, and as I said, I will talk more about the blueprint and its content later in this presentation. Finally, because of some of these conceptual changes and foundational changes, there was a reorganization or a restructuring of the themes within the National CLAS Standards. The standards themselves probably are still very recognizable to those who were familiar with the 2000 iteration, but we really wanted to make sure that the themes really communicated the overarching content and purpose of the standards that were held within. So as you can see, in 2000, we had 3 themes: culturally competent care, language access services, and organizational supports. In this next iteration, we moved to have a principal standard, which is Standard 1, and then the 3 themes became governance, leadership, and workforce, communication and language assistance, and engagement, continuous improvement, and accountability. And we'll go into each of these more fully here shortly. So just we'll look at the next slide ever so quickly, because again, this is simply the statement of intent. But as you can see, it ends with an ellipse. So as to note that each of the standards, this can be considered the preface or the lead in to each of the standards, which now begin with an action verb for each iteration. So now we'll look at Standard 1, which is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. We consider this the principal standard because conceptually the ultimate aim in adopting the remaining standards will result in achieving Standard 1. The purpose of providing effective, equitable, understandable, and respectful quality care and services are to help create a safe and welcoming environment at every point of contact that both fosters appreciation of the diversity of individuals and providers and provides patient and family-centered care. To ensure that all individuals receiving health care and services experience culturally and linguistically appropriate encounters, and to meet the communication needs so that individuals understand the health care and services they are receiving, can participate effectively in their own care, and make informed decisions, to eliminate discrimination and disparities. If each of the standards 2 through 15 are implemented and maintained, organizations will be better positioned to achieve the desired goal of effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So now we move on to the first theme, which is governance, leadership, and workforce, what previously known as culturally competent care. to provide greater clarity on the specific locus of action for these standards. This theme emphasizes that implementing CLAS is the responsibility of the entire system. Implementing CLAS really requires the investment, support, and training of all individuals within an organization. The impetus for implementing CLAS can and often comes from the bottom up. However, if it is an organization's leadership that shapes the culture of the organization through its priorities, expectations, and the behavior that it models. Therefore, the impetus for implementing CLAS should also come from the top down. So within this theme, we move on to Standard 2, which reads, to advance and sustain organizational governance and leadership that promotes class and health equity through policy, practices, and allocated resources. The purpose of advancing and sustaining governance and leadership that promotes class and health equity are to ensure the provision of appropriate resources and accountability needed to support and sustain initiatives, and to model an appreciation and respect for diversity, inclusiveness, and all beliefs and practices, as well as to support a model of transparency and communication between the services, the service settings, and the population that it serves. Standard 3 reads, to recruit, promote, and support a culturally and linguistically diverse governance, leadership, and workforce that is responsive to the population in the service area. And the purpose of this standard is to create an environment in which culturally diverse individuals feel welcomed and valued, to promote trust and engagement with the communities and populations served, to infuse multicultural perspectives into the planning, design, and implementation of CLAS, to ensure diverse viewpoints are represented in government's decisions, and to increase knowledge and experience related to culture and language among the staff. The final standard in this theme is Standard 4, which is to educate and train governance, leadership, and workforce in culturally and linguistically appropriate policies and practices on an ongoing basis. This is to ensure that all of the individuals within an organization know the resources are available, how to access them, and how best to apply them. It also infers that it should happen beyond new employee orientation and should be a continual part of an individual's training and experience within an organization. This is in order to prepare and support a workforce that demonstrates the attitudes, knowledge, and skills necessary to work effectively with diverse populations, to increase the capacity of staff to provide services that are culturally and linguistically appropriate, to assess the progress of staff in developing cultural, linguistic, and health literacy competency, to foster an individual's right to respect and non-discrimination by developing and implementing education and training programs that address the impact of culture on health and healthcare. Now we're going to move on to Theme 2, Communication and Language Assistance. This broadens the understanding and application of appropriate services to include all communication needs and services, including sign language, braille, oral interpretation, and written translation. The standards in this theme will help organizations comply with requirements such as Title VI of the Civil Rights Act of 1964 and the Americans with Disabilities Act of 1990, and other relevant federal, state, and local requirements to which they may need to adhere. Standard 5 reads that an organization is to offer language assistance to individuals who have limited English proficiency and or other communication needs at no cost to them to facilitate timely access to all healthcare and services. The purpose of this standard is to ensure that individuals with limited English proficiency and or other communication needs have equitable access to health services, to help individuals understand their care and service options and participate in decisions regarding their health and healthcare, to increase individual satisfaction and adherence to care and services, to improve patient safety and reduce medical error related to miscommunications, and as previously stated, to help organizations comply with federal, state, and local requirements. Standard 6 states to inform all individuals of the availability of language assistance services clearly and in their preferred language, verbally and in writing. The purpose of this standard is to inform individuals with LEP in their preferred language that language services are readily available at no cost to them, to facilitate access to language services, and again, to help meet federal, state, and local requirements. It is essential that individuals know that the services are available if they are going to be able to successfully utilize them. Standard 7 states to ensure the competence of individuals providing language assistance, recognizing that the use of untrained individuals and/or minors as interpreters should be avoided. The purpose of this is to ensure the competence of individuals providing language assistance, so that they may provide accurate and effective communication between individuals and providers, to reduce misunderstanding, dissatisfaction, omission of vital information, misdiagnoses, inappropriate treatment, and patient safety issues due to reliance on staff or individuals that lack interpreter training, as well as to empower individuals to negotiate and advocate on their own behalf for important services via effective and accurate communication with health and healthcare staff. Finally, Standard 8 is to provide easy to understand print and multimedia materials and signage in the languages commonly used by the populations in the service area. The purposes of this standard is to ensure that readers of other languages and individuals with various health literacy levels are able to access care and services, to provide access to health-related information and facilitate comprehension of and adherence to instructions and health plan requirements, to enable all individuals to make informed decisions regarding their health and their care and services options. Now for the third and final theme, engagement, continuous improvement, and accountability underscores the importance of establishing both individual and organizational responsibility for implementing CLAS. Effective delivery of CLAS demands actions across an organization. This theme focuses on the supports necessary for adoption, implementation, and maintenance of culturally and linguistically appropriate services and policies, regardless of one's role within an organization or practice. All individuals are accountable for upholding the values and intent of the National CLAS Standards. Standard 9 states the importance to establish culturally and linguistically appropriate goals, policies, and management accountability, and to infuse them throughout the organization's planning and operations, or essentially to put CLAS in all activities, plans, and purposes. To make CLAS central to the organization's service, administrative, and supportive functions, to integrate CLAS throughout the organization, including the mission, and highlight its importance throughout specific goals, and to link CLAS to other organizational activities, including policy, procedures, and decision-making related to outcomes and accountability. Standard 10 is to conduct ongoing assessments of the organization's CLAS-related activities and integrate CLAS-related measures into measurement and continuous quality improvement activities. Its purpose is to assess performance and monitor progress in implementing the National CLAS Standards and culturally and linguistically appropriate services overall, to obtain information about the organization and the people it serves, which can be used to tailor and improve services, to assess the value of CLAS-related activities relative to the fulfillment of governance, leadership, and workforce responsibilities. Standard 11, to collect and maintain accurate and reliable demographic data, to monitor and evaluate the impact of CLAS on health equity and outcomes, and to inform service delivery, The purpose is to accurately identify population groups within a service area, to monitor individual needs, access, utilization, quality of care, and outcome patterns, to ensure equal allocation of organizational resources, to improve service planning to enhance access and coordination of care, to assess and improve the extent to which healthcare services are provided equitably. Standard 12, conduct regular assessments of community health assets and needs and use the results to plan and implement services that respond to the cultural and linguistic diversity of populations in the service area. This purpose is to determine the service assets and needs of the population in the service area, or to conduct a needs assessment, to identify all of the services available and not available to the populations in the service area, conducting a resource inventory and possibly a gaps analysis. These are also areas that are highlighted within the business case, because if you find an unmet need, obviously that is an area of potential organizational or practice growth. To determine what services to provide and how to implement them based on the results of the community assessment, and to ensure that health and healthcare organizations obtain demographic, cultural, linguistic, and epidemiological baseline data, both quantitative and qualitative, and update the data regularly to better understand the populations in their service areas. We have all witnessed communities that change quickly, and it is imperative that the data collection happens routinely enough to capture any of those changes to make sure that the services being provided are still appropriate. Standard 13, to partner with the community to design, implement, and evaluate policies, practices, and services to ensure their cultural and linguistic appropriateness. The purpose of this standard is to provide responsive and appropriate service delivery to a community, to ensure that services are informed and guided by community interests, expertise, and needs, to increase use of services by engaging individuals and groups in the community in the design and improvement of services to meet their needs and desires, to create an organizational culture that leads to more responsive, efficient, and effective services and accountability to the community. We often say that the community or the patients or the individuals that we are seeing and serving are our best access, best assets, best resources, and the best experts in the care that they are most interested in receiving and essentially what they need. Standard 14, to create conflict and grievance resolution processes that are culturally and linguistically appropriate to identify, prevent, and resolve conflicts or complaints. This is to facilitate open and transparent two-way communication and feedback mechanisms between individuals and organizations, to anticipate, identify, and respond to cross-cultural needs, to meet federal and/or state regulations that address topics such as grievance procedures, the use of ombudsman, and discriminations policies and procedures. And this is another place to underscore the importance of making sure that the grievance process is culturally and linguistically appropriate, because if the grievance process only takes place in English, the individuals who have limited English proficiency or other communication needs may not be able to participate in it, and therefore a lack of grievance responses may not actually indicate that there are not other problems at hand, but that there is a problem, in fact, with the grievance process itself. Finally, Standard 15, communicate the organization's progress in implementing and sustaining CLAS to all stakeholders, constituents, and the general public. The purpose of this standard is to convey information to intended audiences about efforts and accomplishments in meeting the National CLAS Standards, to learn from organizations about new ideas and successful approaches to implementing the National CLAS Standards, to build and sustain communication on CLAS priorities and foster trust between the community and the service setting, as well as to meet community benefits and other reporting requirements, including accountability for meeting healthcare objectives in addressing the needs of diverse individuals or groups. Now, I know that was an abundance of information that I went through rather quickly, but I wanted to make sure that we left enough time for question and answers. I just have a couple more slides that I want, and a couple more points I would like to make before we open that up for discussion. If we move on to the next slide, where can you find more information about the National CLAS Standards? As I alluded, there is a document, I believe it is nearly or just over 200 pages of information and resources to help individuals and organizations in a variety of topics, help them to implement, inform, and guide their process through the National CLAS Standards. And as I said, it discusses implementation strategies for each of the standards. I hope that as we went through, you were able to hear many allusions to many of the other standards and guidances that are out there in the field. The Joint Commission, with their emphasis on communication and language needs, a focus and an inclusion of health literacy, non-discrimination, and those sorts of things. We wanted to make sure that the National CLAS Standards built upon and was congruent with all of the other pieces that are going on in the field while still advancing culturally and linguistically appropriate services. But we never want this to be an undue burden. So one more slide. The blueprint, again, walks through the case for class, the business case, talking about malpractice, legislation, building your place within the market, as well as the social justice piece, making sure that you're addressing the needs of different demographic groups, addressing health disparities, and improving the quality of care overall. And then there are standard by standard chapters which outline the purpose, what is the intention, and those are some of the pieces that I alluded to in today's presentation. A description of each of the standards. So what do we mean? It parses out the different parts of the standards and goes into more detail. And then there are strategies for each of the standards that articulate strategies as well as resources. And these are big picture strategies and big picture resources because, we want to make sure that what we've outlined here is inclusive of health and healthcare organizations, and that everything has an opportunity to be made more culturally and linguistically appropriate and therefore more accessible and moving us closer to health equity. So then we'll put up the last slide, which is where we can find an abundance of resources as well as the blueprint and a list of the standards and other documents, www.thinkculturalhealth.hhs.gov. Think Cultural Health has proven to be a trusted site for health professionals to turn to for information and education related to class and health equity. Successful implementation of the enhanced National CLAS Standards will depend on each of you on this call and all of those who you can help spread the word to. And we look forward to the opportunity to collaborate with each of you in the promotion, implementation, and assessment of these standards. And with that, it looks like we have about 15 minutes remaining for questions and hopefully answers.
Great. Thank you very much, Darci. And I also see that our center director, Dr. Levis, joined us. Dr. Levis, I unmuted you. Would you like to share a few words?
Well, I just want to thank Darci for coming on and sharing this with our group, and thank you all for being on the webinar today.
Great. Thank you. So I see we have a number of questions, and that's always a good thing. I see several people have raised their hands, and I've also received some questions that have been typed in. So I'm going to first start with the people who have raised their hands, and what I will do is I will state what your name is, and then unmute you, and then we'll see if you'll be able to ask your question verbally. If that does not work due to the audio pin controls, then what I would ask is that you would type your question in. So let me start with Shanaz Davachi. I'm going to unmute you. Shanaz, are you able to speak? Shanaz? No, okay. So I'm going to try Omar Torres Cortright. I'm going to unmute you. Omar?
Yes.
Oh, good. Go ahead.
Yes. Hi. Yeah, I actually typed in my question as well. I'm not sure if it's okay for me to say it verbally.
Sure, go ahead.
Yeah, so I am from Chicago. We are here at the Lurie Children's Hospital in Chicago, and we recently, because we moved to a new facility, we redid our signage. Everything is bilingual, and we do provide bilingual. We do provide Spanish discharge instructions for Spanish-speaking patients. And that accounts for 90% of our limited English proficient population.
Mm-hmm.
So I was wondering, in accordance to class, I saw there's a lot of talk about written materials for all LAP patients, and I was wondering, is what is the standard? If we are taking care of 90% of our LAP patient population, is that enough? Obviously, the creating materials in other non-Spanish languages represents a big challenge and can be very costly, especially to provide on-demand access to these documents. So I was wondering, if you had any thoughts on that, and what would be, the appropriate standard there.
Absolutely. Thank you so much for that question. The National CLAS Standards are essentially a guidance document. They do not represent any law or regulation per se. That said, Title VI and the Executive Order 13166 state that if you receive any federal funds, then you are providing language assistance is a mandated part of your mission. How you determine what your level of I'll say liability or responsibility is determined by what they call a 4-factor analysis, and you can find out more about that at www.lep.gov, and that can walk you through that process, and it's all based on I believe percentages and populations served and those sorts of things. So there is no set rubric, because obviously a hospital in Chicago and a community health center in Fargo, North Dakota, or Manhattan or Oakland, California will all have very different populations and very different requirements and resources and the like. So it's really the 4-factor analysis is the best way to determine your level of responsibility in that arena.
Excellent, thank you.
Great, thank you. And I will go ahead and mute you, Omar. Thanks again. And so Shanaz was able to type in her question, so thank you, Shanaz. And her question, first, Darci, she's thanking you for a great presentation, but then she's wondering, how do you monitor whether these standards are complied with, and what happens when organizations are not acting on these standards?
Well, as I indicated in my my response to Omar, the National CLAS Standards do not represent any kind of law or regulation. So there is no one that is going to come and check to see if you are in compliance with the standards per se. That said, things like Title VI, Executive 13166, regulations and accreditation standards put forth by the Liaison Committee on Medical Education, the Joint Commission, and other entities all require elements of cultural linguistically appropriate services, and we really hope that the National CLAS Standards help provide a blueprint or and a tool for you to help meet those overarching requirements. In addition, we know that when, from a business case and a social justice, if you will, case, we know that individuals who have limited English proficiency tend to have higher readmission rates, tend to have longer stays in the hospital and undue and unnecessary tests. And so from a business case perspective, adopting the National CLAS Standards can be incentivized that way. So will we be knocking on your door and asking if you are in compliance with all of the 15 standards? No, but can it help meet many of the goals and expectations of not only your institution, but institutions that do determine funding, regulations, and the like? Then the National CLAS Standards can help provide that guidance document to achieve those goals.
Great. Thank you, Darci. We have a question here from Jeffrey Ring, and Jeffrey is asking the online CME training, A Physician's Practical Guide to Culturally Competent Care, that is currently available on the Think Cultural Health website. Has that been updated to reflect the recently released CLAS standards?
Hi, Jeffrey. They have not. The continuing education programs on Think Cultural Health have not yet been updated. That is in process. In addition to updating to reflect the new National CLAS Standards, we want to do some community outreach and some needs assessments to determine what other updates the program may necessitate. The physicians program that Jeffrey is referencing was published in 2004. And so we imagine that there may be other areas that we want to address in addition to the National CLAS Standards. So we want to make sure that we do that in the most strategic and successful way possible.
Great. Thank you, Darci. Bobby Darren has a question, is wondering, is there a crosswalk available between the previous standards, the ones issued in 2000, and the most recent standards?
Hi, Bobby. These are all names I recognize. There is a crosswalk. It appears in the blueprint document. I can't tell you the page number off the top of my head, but it does provide a crosswalk. Essentially, the new standard, or what made the standards go from 14 to 15, is now what is standard 2. So 1 shifted up and everything else shifted down. But there is a physical crosswalk within the blueprint document. Okay,
great. And in addition to that, this kind of goes with this, but will there also be a crosswalk, or is there currently a crosswalk to the Joint Commission standards in the blueprint as well?
That is also in the development phases. We are in communication with the Joint Commission, and we'll be working to publish one of those as quickly as possible.
Great. Thank you, Darci. The next question is from Pat Rossley, and the question has to deal with the physician population. Will the new CLAS standards be publicized to the physician population with the approval of the American Medical Association? So basically, how will the word get out to the various physician practices and physicians as a whole?
We are working with a variety of partners, including the AMA. We had an individual from the AMA serve on our advisory committee. So we are working with partnerships with the AAMC, the American Association of Medical Colleges, to help move the word out that way, and they work with the entire continuum of medical education. So there are a multitude of ways, but again, we are, this is going to be ultimately a snowball, maybe not ultimately, but in part a snowball effort. So we are asking everyone to help us spread the word. help us disseminate the information and the importance of the content of the standards and the intent of the standards to ensure that multiple people, multiple disciplines, and as well as all physicians have awareness of and access to the resources that the National CLAS Standards provide.
Great. Thank you very much. So we have a number of other questions that have come in. Oh, so Darci, one question several people have asked is, will your contact information be available?
Yes, I realized a little too late that I had been remiss in adding that to the slide. My email is Darci, D-A-R-C-I _Graves, G-R-A-V as in Victor, E-S, at sra.com. And please feel free to email me at any time, and I will make sure that I provide Cherie with an updated slide deck that includes a slide that has that information, so that when it gets posted to their website, it is also contained there as well.
Great. Thank you, Darci. We've also had, one point we had is that Nan Crockett must have the blueprints in front of her. And I think she said that it was on page 165, if anyone has it handy in front of them. So if you go to page 165, that's the crosswalk is listed there. So thank you again, Nan Crockett, for that. We have a couple of questions that came in regarding Standard 7, which has to do with ensuring the competence of individuals providing language assistance. Yes. And a few people are wondering, do you have any thoughts about this? And what about to patient or client preference if they indicate they would prefer to have a family member or a community member rather than the official bilingual staff member or interpreter from the institution?
Okay, I'm going to address that as a two-parter.
Great, thank you.
In terms of assuring the competence of a staff member, and I'm going to use that in the broadest sense of the term, whether it be from an outside service or an individual who is a bilingual employee who has the designation of being an interpreter. It's really, there are a couple of national certifications now. There are local groups that are able to assess proficiency in the languages. Interpreting and translating are very much a skill, and just because you speak both languages does not necessarily mean that you are have a competency in both languages, and or the skill to interpret per se. As part of the competency training, there is also making sure that there is the appropriate medical terminology within the person's language, because when we're talking about informed consent and surgery, just because you are, if you are a native speaker, that doesn't mean that you necessarily have the medical terminology necessary to communicate the information at the level it needs to be communicated at for many of the interactions that a patient may have during diagnosis or during consenting to a particular format. So there are a number of organizations out there who can provide tests and certifications and the like, but it's really key to make sure that that the competency is there. For patients who prefer to have that friend or family member, this is always a very delicate and sometimes hot button issue. There are a number of approaches that can be taken. I have heard everything from, if the patient truly wants a family member or a different interpreter, to make sure that they sign a waiver to that effect. I think, and and wearing my Darci hat, I think even more closely, you know, allowing the patient to have their preferred interpreter, but to still have the bilingual interpreter or the hospital or healthcare organization's interpreter present, who is able to step in to make sure, in case the information isn't conveyed in the way that it could be or should be, for an accuracy and safety reasons. Because if information is misinterpreted or mistranslated, then a patient's safety can be compromised. There is no great answer to that question. So yeah, unfortunately, that's a not uncommon question, but one that is difficult to answer.
Great. Thank you, Darci. We also had a point of clarification from Maria Carrion Errors, where she was saying or mentioned that the skill sets for translation and interpretation are also not the same. So
correct.
Thank you for that clarification. Yes, and we do recognize that. So we are currently out of time. I want to apologize to those whose questions we did not get a chance to answer. I also did want to recognize Dr. Leveist quickly, because he did serve on the National Project Advisory Committee for these efforts. So thank you, and to the many other people who Darci mentioned at the very beginning of the webinar. And one quick reminder is that we did record the webinar, so both the actual presentation as well as the webinar recording will be posted to our center's website. Several hours after the webinar, you will be receiving an email with an evaluation to complete regarding the webinar, and we would appreciate if you could complete that. And we'll also provide a link to how you can access the presentation as well as the webinar recording. And with that, I would like to thank everyone for their time. I would like to especially thank Darci for a wonderful presentation, and I hope you have a great rest of the afternoon. Thank you.
Thank you, everyone.
Thanks.